Dr. KHALIFÉ is going to moderate.
And I welcome everybody to ask questions. Otherwise, I was tasked to ask challenging questions to the panel members. Please come up.
Hello, thank you all for wonderful talks. Excellent accents, particularly on the first two speakers. I wondered, Dr. LILLICRAP, with the groups who decreased their bleed control, I think it was the 9.7%, was there any analysis, was there any commonality found either biologically or environmentally that might sort of help predict people who are less likely to respond?
Yeah, that's a great question, thank you. So this very small numbers of individuals who had no response to their therapy, remember that was the factor VIII study that I was referring to. Unfortunately, there's nothing that identifies them ahead of time. I think one of the problems we have, especially with factor VIII gene therapy, is that the predictability of the things that I'll repeat myself, the level of the factor, the rate in which it will fall off, and whether you're going to get any response is entirely unpredictable with individual patients. So if any of you are sitting down with a physician, you say, where will I be in this scale? We cannot say.
Sorry, and I didn't do my job. Anybody who's answering a question, you have to be like a rock star and talk 3 fingers from the microphone, so don't be shy.
All right, I might ask a question to Luke and Rick. If you can take us a little bit through the conversation that you had with your HTC about gene therapy. What was that discussion like? What did you feel was missing from that discussion, and how long did it take you in terms of back and forth conversations to make a final decision?
Okay, there's been a deferral. Hi, Luke. I don't feel like there was anything missing from, I think Shannon's here, so I'll be careful. I don't, yeah. It was fantastic. I would only add that I think I came to my conclusions about withdrawing based on coming to events like this largely, so I wonder about folks who don't come to things like this. So I think there's room to improve the access to the information we need to make those decisions.
I'd agree with that. I think it's very easy to forget that of a large majority, at least in the UK, a large majority of people aren't actually actively involved in the advocacy community, but they're still having these conversations. I was not oblivious to the fact that my haemophilia centre, being a trial PIC site, had recruitment numbers. And that's perhaps why I was asked multiple times, have you given it any more thought? So I kind of knew the ball was in my court, but I'd also had that same approach when, I was tried to be moved on to an extended half-life at one point, kind of asked a few times. But the one thing I will say is, each time I spoke to someone through my haemophilia centre, any questions I had, they were more than willing to give me all the information I asked for. I think that's just the tricky thing, though, empowering all the other people in the patient community to know what questions to ask and feel that they have permission to. And I drove my clinician Pratima mad even after I started the trial, just asking, can you send me a paper on this? Like just random proteins that had gone up, and they were like, you've got to come back in to get a blood test. And I was like, why, what's happening? And then, asking for articles, and she was like, do you really want this information? I was like, yeah, just give it to me. I'm bored.
Thank you both.
Oh, hi, this is Kelsey Brose from Saskatoon, and it's a bit of a comment and a question, especially to Luke and to the panel members who've had dealings with gene therapy. So back in February, and maybe people from Saskatchewan don't know this yet, but we were selected as a site as well for the same one that was shut down in February. So we were about to make the announcement, and then as you said, Luke, we were just gutted to find out that it was closed to enrollment just as we arrived at the start line. But one of the major things that we were really worried about was in Saskatchewan, we cover the whole province from Saskatoon. And so we had one patient we had planned to approach who was 4 hours away, and how we would deal with that for somebody who's so remote. So Luke, I'm curious to see what you would say. What would it have been like if you'd lived 4 hours away from the research center? And does anybody in the panel have any experience dealing with remote patients and studies? Thanks.
Yeah, it's a really important consideration for a country like Canada. There's just, it's just so vast. And we talk about the hub and spoke model a lot in the UK and in Europe. And I think there is recognition that, it's not going to be as possible as in other countries. People in the UK here have worries about if I'm based in Northern Ireland's probably not going to be a comprehensive care treatment centre. So, I'd have to do a day trip over to London or to somewhere in the north of England. And that's still an hour or two. And we're all freaking out over it in tiny little old England. And it's, that was one of the things that just, when I spoke to people from all over Canada when I was traveling, the spaces between places. And, it'd be a real shame if something like geography prevented people from getting access to gene therapy. So I don't have the answers, but you guys have a task on your hand, that's for sure. Maybe we can use drones or something. That would be cool.
So I think funding will be important, funding transportations and accommodation for patients. So we do that on the oncology side, for example, as part of the CAR T cells program that was integrated into the program. So it will require advocacy to get this planned and sorted out. But it is an important question. We have a very wide country. I'm blanking on the rest of the answer, but we'll come back to it.
I'd love to hear on this from some of those of you who've been following gene therapy for decades or more. So we know Hemlibra came onto the scene a little bit more rapidly. Have you noticed a trajectory of how gene therapy is welcomed by the community, or what that discourse is, some of those changes, or any insights onto how the patient community is taking it now versus where they may have been taking it 10 years ago or 20 years ago?
Okay, I can start that, and some of my colleagues will pipe in as well. When we first started talking about gene therapy, all we had was standard half-life, recombinant factor VIII and factor IX. And so gene therapy was the shining city on the hill. It was the holy grail. We didn't anticipate at the time long-acting factor IX concentrates that you could take every 10 to 14 days. We didn't anticipate long-acting factor VIII concentrates. We certainly didn't anticipate subcutaneous therapies that you could inject once every 1 to 4 weeks. So I think your question is very perceptive. The position in which gene therapy now kind of occupies in the firmament is now a very crowded field in which there are very attractive alternative approaches to therapy. And we heard some of that from Rick. That was part of your decision making, is that you had a very good alternative that didn't involve frequent intravenous infusions. So the landscape has changed quite a bit, and it's an embarrassment of riches. It's wonderful, but it makes decision-making much more complicated.
I think I've been following this from a patient perspective for a long time, and I think, up until, up until that meeting in Florida about 2016, we were thinking 5% would be fantastic. That was the goal. And suddenly everything changed, and the numbers came in much higher, and people's expectations changed. And so that was sort of the second phase. And now we're into the third phase, where people are seeing the actual results. And we heard about unpredictability, variability, durability. And so now people are really looking at this with, I think, much more of much more knowledge. And so it's really been a bit of a roller coaster. And you can't repeat often enough that A is not B, and it's quite a bit different. And perhaps Mark can give his own. By the way, I have hemophilia B. I was very interested. I'm too old. 65 was the cutoff. I was 66 when I had the chance.
Oh, 2 mics. So if David's old, I don't know. I'm giving a talk on aging next week, and so I guess I'm old too. So I think there's pretty universal belief that we all want to be cured of the disease. I mean, sort of as was articulated earlier. And I'm very much a divider now, where before we sort of lumped gene therapy, I think that is one of our biggest challenges now, is that A and B, I think, are very different conversations in the thought process. So there's been a lot of research that's been published on what patient preferences are, what they're looking for when we've developed the core outcomes that we thought would differentiate successful gene therapy from current standard of care. We identified a different set of clinical issues, and the annual bleed rate was really only one of those. And so as we've gone through that process and continue to ask people why they're making their decision, we're learning that it is very individual, that depending on who you are, where you are in your life, what you're thinking about, and there could be very good reasons why, whether I'm an 18-year-old or whether I'm a 65-year-old, why it might make good sense for me, particularly if it's hemophilia A, that I want my decade without hemophilia. When you're getting older, you have less family support, your venous access is worse, your risk of falling is greater. You may say yes then when you didn't want to say yes earlier. So I think the hemophilia population is going to be making a decision very differently based on who they are. Hemophilia B is perhaps an easier and more homogeneous yes based on where we see the data, but I think the hemophilia A side could become very personal and temporal, sort of where you are in your life.
Just really quickly, so recall that the first successful hemophilia therapy was back in 2011, so we're now 12 years on. Things have not changed a heck of a lot. The factor VIII gene therapy, Roctavian, was approved in Europe back last August. We're waiting, I guess, to hear about the FDA outcome at the end of June, so in about a month's time. If FDA says no, nothing is going to change in gene therapy for at least the next 5 years, I think. So I think if you think that things are going to change next year or in 2 years, it isn't. This is complicated enough that the next generation is going to take at least, I think, 5 years. So what you're looking at now is the menu.
And I wanted to add just a placeholder for what gene therapy may mean. Is all true if you think of North America and Europe. But maybe little changed here, nothing changed for the rest of the world. And if we don't get new treatment that assume different capacity and treatment paradigms, that there will be no hope for 80% of the population, 75% of the population on Earth. So I think that should always be part of considering if developing or not, if continuing or not, if supporting or not gene therapy for hemophilia.
Can I just build on what Alfonso said? Because I actually think the equation of saying yes may be very different for somebody outside the developed countries when they have little access to anything else. I mean, I am heartened that St. Jude, for example, is getting ready to start a Factor IX trial in Sri Lanka, in Thailand, in Vietnam, in Peru. I'm skipping one, Nepal. And they're going into 5 sort of emerging countries to see if it is feasible to deliver. And it may well be that generation skipping, technology skipping event for many countries. So it's much like many countries got IMI before, some of the developed countries. So I'm not absolutely certain that they're going to have to follow in everything that we're going to do.
You get the last question, Wendy.
Yes, I do. I have the privilege of having a lot of exposure to everything that the CHS does, and that education has really helped me. My question is going to be more reflective of the people that might not know the process of approval. So if we have such a lot of variability, safety, efficacy issues with the Factor VIII gene therapy, why would Health Canada approve it in the first place, in the FDA?
You all get 1 minute and a half to answer the question.
We might be late for dinner, guys.
I think it's a good question, and I'm not sure what they'll do. We're not sure what FDA will do. I mean, they've delayed several times, so it's not a slam dunk. Given the alternatives, but I can't predict the future. But there's even a question for us as a patient organization. Even if they do approve it, Do we advocate for it? And there may be people for whom we should, but not everybody. So it's a tough one.
I would point out that in the United States, the NHF, the National Hemophilia Foundation, which I obviously spend quite a bit of time with, coupled with the World Federation of Hemophilia and the European Hemophilia Consortium, did submit a letter to the FDA requesting for a RIMS, a risk mitigation strategy, to be coupled with any gene therapy approval. They denied that request as it came to hemophilia B for Hemgenix. They have not yet responded for factor VIII. So it is possible that it could come forward with a whole, with a strategy around how to minimize the importance of education, sort of where it's done, sort of the other testing requirements. And we're optimistic that the FDA will understand the difference between the two. I can't guarantee it, but it's possible.
All right. On that note, we will close the session for gene therapy. Thank you, everyone, for sticking around.